And today we're going to be talking about foundations of clinical reasoning. So I'm very excited to see so many folks here. Oh, and when you do respond in the chat, be sure it's set to everyone so everyone can see your messages, unless you're intending to only send it to the host and panelists. But if you have a specific question today, the Q&A button at the bottom of your screen is very, very helpful for us. That helps us collect questions. So if you are able to use that Q&A button for any specific questions you might have, that's really helpful for all of us. So while everyone is joining, I'll thank our webinar series team. These are the folks who are making this possible here at Lecturio, and we appreciate everybody on this team. It takes all of us to make these events happen. Today we aren't going to have people unmute to ask questions, so if you do have a question, please put that in the Q&A box. That is the best way to ask your question. And just a reminder, we do have live Spanish interpretation today by a human being, not AI. So thank you to Zita Thompson, who will be providing that interpretation for us today. If you would like that interpretation, at the bottom of your screen, there is a globe icon that says, I believe it says interpretation. You can click on that and choose the Spanish audio channel, and you'll be able to hear that simultaneous translation. So for those of you who would like that, thank you to Zita for translating for us today. And I'll be your host today. My name is Sarah Keith. I'm the Director of Learning and Institutional Success here at Lecturio, and I would like to welcome you here today on behalf of Lecturio. I am very excited to introduce you to our guest speaker today. Dr. Raja-Elie Abdulnour is the Editor-in-Chief of NEJM Journal Watch, Editor of Clinical Development and AI Innovation at NEJM Group, and a U.S. National Academy of Medicine Diagnostic Excellence Scholar. So I'm very pleased to introduce to you Dr. Raja-Elie Abdulnour.
Hi, I'm excited to be here. I'm going to share my screen. Great. Can you see my slides, just to confirm?
Yes, we can.
Okay, awesome. So again, my name is Raja-Elie Abdulnour. I'm a practicing pulmonary and critical care physician at the Brigham and Women's Hospital, faculty at Harvard Medical School. As of June 1st, Editor-in-Chief of NEJM Journal Watch, a sister publication of the New England Journal of Medicine, where we summarize and survey and summarize important literature for clinicians. I'm also editor in clinical development and AI innovation. I'm very interested in how AI is transforming medical education in general, in particular clinical reasoning, and awarded a scholarship from the National Academy of Medicine around the work that you'll be seeing today. So let's get started. So what I'll be talking about today is how to think about clinical reasoning as an activity as opposed to a competency. You know, going through med school and residency and my own training, it's always been this sort of nebulous competency. But what does it really mean in terms of what are the external aspects of clinical reasoning that educators should be looking for and assessing, so that they can give the right feedback to the learner and so that they could grow. So my foray into clinical reasoning education is around the problem of error and an error related to diagnosis. And so here I'm just going to sort of briefly just talk about the diagnostic process. Now, the diagnostic process is clinical reasoning, which is at the center, is only part of it. But really, the diagnostic process starts at the patient's home or whatever they are in their setting when they start having a problem, a clinical problem. And then they need to, if they recognize the problem, then they need to seek care and then they access the clinic. And when they access the clinic, and this is where the encounter happens with the clinician and where clinical reasoning occurs. And I'll go through the clinical reasoning process in a minute. But the outcome of this clinical reasoning process is a differential diagnosis and a management plan. And then the process involves to communicate the diagnosis back to the patient so we can inform them on potential solutions, but also communicate it to the rest of the health system, your team members, the technology, the EHR, and to initiate treatment. And then the treatment itself will inform our clinical reasoning. And ideally, pain becomes gain, and we can help our patients. Now, the problem is that this process is complex. It happens in a very difficult environment, which is the health system. The amount of knowledge required to solve patient problems is tremendous. And so there's really the incidence of delayed, missed, or incorrect diagnosis is very high. Even in the outpatient setting, it's up to as high as 20%. And in fact, a recent study in the US showed that there's an estimated close to 800,000 people that are either permanently disabled or die from an error in the diagnostic process, and around a quarter of these are related to problems in clinical reasoning. And which is why the National Academy of Medicine states that addressing diagnostic error is a moral, professional, and public health imperative. And fixing diagnostic error is a massive, massive endeavor. But where we are here today to talk about is, well, how could we improve the diagnostic process by teaching the diagnostic process? And that's where, and so let's get going on that. So I'm going to take a step back on how humans develop competency in any task. In general, we go through life problem solving, right? So we have a problem. We sort of, you move around and you recognize the problem, and you want to solve that problem. That could be how to order food from an application to how do I take out an appendix. And to get to that problem, to solve that problem, you need competencies. You need a set of skills and set of knowledge that will then lead to an activity, so a response to the problem, and that activity is going to have an outcome, right? And so this flow of problem, activity, and outcome is really what we want to develop in our learners. We want to help our learners problem solve so that they can get to a good outcome. And so, for example, if we place this in the medical education context, if you have a problem such as respiratory failure, a patient has a new terminal diagnosis, you need to fill a pre-authorization form in the United States in particular, so that the insurance can then provide the medication to the patient. What you want as an outcome is you want to provide the patient respiratory support. You want to help the patient consider hospice or how to get them a drug. And so you need competencies that will lead you to their corresponding activities. So, for example, if a patient has respiratory failure, the competencies required to get respiratory support include clinical reasoning, communication, system-based practice that will lead to the activity to decide to intubate, deliver bad news, and prioritization. So that is sort of the schema in general on how we develop competency in anything. And so now, what competencies, which is the set of skills, is really very much dependent on knowledge. For me to know how to approach and reason through respiratory failure, I'm constantly going to my memory, my internal knowledge fund, my sort of the knowledge that I've organized in my brain to inform my clinical reasoning. And the reason I put this here is to really highlight the importance of knowledge in addition to skill and processing. Now, now how we learn is really, if you think about if you're just walking around on your own in a hospital and you're doing all this stuff, the main way we learn is through the outcome of our problem-solving activities. So if the outcome is favorable, then that consolidates our knowledge. I've done something correct. That means that both my knowledge and my competencies, this whole process has worked. If the outcome is unfavorable, then I need to change something. And so that helps you calibrate your knowledge. If you have no idea what the outcome is, which often happens, for example, I work in the intensive care unit, I start a plan, but then when my shift ends, I leave, I don't know what happens. I really don't get any calibration. And so that does not happen. And this is a form of unsupervised learning. This is a form of learning through trial and error, right? Now, if I only depended on trial and error, if you take a person from the street and you put them in a hospital and you ask them to learn medicine, it's a very, very inefficient process. But instead, what we do is we teach them. We actually support and grow and help them grow their knowledge fund by providing them with supervised learning, which is where we tell them, this is asthma, this is heart failure, and this is COPD. And we support that knowledge fund so that once they're in the hospital, they have the knowledge fund to recognize it. Now, what educators do, our main task as educators is really to help assess and then provide feedback. And the assessment, it can happen at the level of the outcome. So, for example, you have learners in the, you have your students that are coming back from an observership or a clerkship, and you have a sense of how they did, you have a sense of the outcome from their patients. You can assess that, and then you can tell the student, based on what you did, based on the outcome of your problem solving, this is what you should do, and which is a form of tutoring. Another, the classic way of teaching is by providing students and learners with the information they know. So this is the typical, read this textbook. This is a lecture. This is a video, right? And a lot of and Lecturio is filled with that amazing tutoring, external knowledge to provide. A classic way to test is the multiple choice question. And so I call this like outcome-based learning. Now, if you think about the multiple choice question, which is a classic form for assessing and practice in school, is you provide a student with a multiple choice question. That's the problem they need to solve, right? Solve this multiple choice question. Now, the activity that they need to do is they need to choose the best answer, right? And then based on their best answer, the outcome is a score. And based on the score, they get certified. This is how we certify students and physicians and clinicians everywhere, is through these board exams, these certification exams. And now, for them to choose the best answer, they do require competencies and knowledge that are really steeped in medicine. But if you think about the competencies required for this best answer, a lot of it are about recall of information processing, and then prioritizing the 4 or 5 choices in the multiple choice exam, right? And then now we can use multiple choice questions to teach and to learn, specifically by assessing their score. So if I get the score of a multiple choice question exam from a student, from the score, I get a sense of their competencies and therefore an indirect information on their knowledge fund, and then I can provide them some feedback, right? I can say, you didn't do very well in these set of questions around cardiac physiology. Here, I'm going to help you. I'm going to help you calibrate your knowledge, or I'm going to reinforce your knowledge. But the problem is that we're not really assessing their activity, and to really assess their activity in the context of multiple choice question doesn't make a lot of sense. Like, am I going to look over their shoulder and assess how they're actually prioritizing a question? There's not a lot of value in it. However, if you're there looking at how they're prioritizing their choices, in fact, it gives you a window into their competencies and then indirectly into their knowledge fund. And the problem about multiple choice questions is that what you're assessing is their ability to choose the best answer in a multiple choice question, which is far removed from what happens at the bedside. And so how do we think about assessing and teaching and giving feedback around more patient-centered activities like communicating a differential diagnosis? And so this is really the framework for competency-based medical education. And so if you think about differential diagnosis and clinical reasoning, again, the problem is the chief concern of the patient. The activity is communicating a differential diagnosis. And the outcome is that the patient knows, or the educator knows, what is the cause of the concern. So this is sort of diagnosis in a nutshell. This is what we want to be able to assess, which is this differential diagnosis. And by assessing how they come up with a differential diagnosis, by seeing them, by observing a learner going through a differential diagnosis, we can really get a sense of their competencies and their knowledge. And so you can see here, by assessing assessing that activity, right? By assessing how they're reasoning, how they're listing a differential diagnosis, it gives us insight into their competencies. And we can tell them, I heard how you reasoned through the case and how you came up with your differential diagnosis. And so I have a good sense of your competencies. Let me help you, let me provide you feedback, and let me coach you so you can improve your competencies. So it's no longer about the outcome. It's no longer about whether they're right or wrong. It's more about how did they get to the differential diagnosis, and providing that critical feedback. And this is nothing new. Direct observation and assessment of activity is really the cornerstone of residencies and clerkship and observerships, where you as educators can see a learner think about a case and provide them immediate coaching. I learned the most in the first 6 months of my internship after medical school, where my chief resident was at my side, listening to me think about a patient, asking questions. There's no secret there. Now, this is taken from I did recently a talk on clinical reasoning education and entrustable professional activities in pediatrics. Just to orient you here, the headers here, 1 through 17, there are the 17 different entrustable professional activities in pediatric. And if we look at the different steps of clinical reasoning, then you can see here that clinical reasoning is in fact part of almost all competencies, anything, including, for example, communicating bad news. A lot of it is about getting a sense of where the patient is, where their state is, the context. It's about problem solving. It's about coming up with a series of different hypotheses on how to communicate the bad news and then doing so. So the way to teach clinical reasoning is to really try to demystify clinical reasoning. How do we change, how do we teach the science behind the art of clinical reasoning? We all think about for example, as a student, I had a challenge with a particular patient, and then I was surprised when I see the attending come in, and within seconds, they're able to come up with a differential, right? So this sort of like this mystique of being able to do so. And for us to be able to teach and make sure that people like me can get better in the clinical reasoning, what we need to do is we need to break down the clinical reasoning into distinct activities. And so you think about, for example, a chief concern, right? So if a patient comes in with a chief concern of, I hear whistling when I breathe at night, if we break down the clinical reasoning process into different activities, then we can start assessing them. So the first one is data acquisition. Like we want to be able to see a learner gathering data from the patient. And so by observing them acquiring data, we can then get a sense of how good they are at data gathering. Are they able to use semantic qualifiers? Are they able to convert I hear whistling when I breathe at night to nocturnal wheezing, right? Are they able to communicate these when they're presenting at rounds, for example? Are they able to communicate these symptoms, these patient speak into a form that's appropriate? Now, once you've acquired data and the learner has written the problem representation, then there's an inductive reasoning process. If you see at the bottom here, what I'm trying to represent is that everything is data, right? So this is the patient with the red dots are the problem. This is the patient. Everything about the patient is data, but the patient is in a hospital setting. There's a context. They're at home or whatnot. That's important. This is an X-ray. There's something abnormal in the X-ray. All of this is data. So that data gathering step is critical. Now, once the data is obtained, what happens in the mind of a learner is that data is merged and is embedded, and an inductive reasoning process happens where the data is chunked. So when you see a patient, there's a potentially 10,000 individual pieces of data. The result is a one-liner. And so that inductive reasoning process, this writing the one-liner, is an essential part of reasoning. This ability to induce from data, what is the problem? What is the problem that this patient really has, right? And then once you have a sense of the problem representation, once you've identified from the sea of data, what is the problem I need to solve, this is when you go into a deductive reasoning mindset and where you generate hypotheses, okay? So this is the problem here, and you can see represented in red here. Okay, now this is the problem. What are the different possible hypotheses? What are the potential solutions here for this problem? Now, the first thing that happens is if you're familiar with this problem, if you've seen this problem before, so for example, I'm a pulmonary critical care physician, I'm very familiar with dyspnea. Very quickly, I have 4, 5, or 6 illnesses that come up on my differential. And that's because I've seen it so often, I don't even need to think about it. And so that's the dual process theory coming in here, where we talk about system one reasoning or fast thinking, which is very much dependent on biases and heuristics. And heuristics are good. We want to encourage people to think fast because thinking fast is efficient. If we're going to be thinking slow every time, we'll never go through our day, and especially in acute settings like the emergency room, emergency department, or the intensive care unit. Now, if you're not familiar with a problem, or if you want to dig deeper, and then you go into more of an analytical reasoning. And this is where you have system 2 reasoning. And this is where you take a diagnostic pause. This is where you slow down and think, okay, this is a patient with acute dyspnea and fever. I immediately thought about these 3 or 4 diagnoses. Now I want to make sure I don't forget anything. So this is where I look up a diagnostic schema from a textbook. I go to my lectures in Lecturio. I ask a consultant. I ask my chief resident. I ask a colleague. This is a slower process, but it's a process that makes sure that I don't miss anything. Now, once I have my differential diagnosis, then what happens is I confirm my differential diagnosis in a step that's called illness script instantiation. Now, what's an illness script? As we go through, as a learner reads a textbook, review articles about asthma, and as they see patients with asthma, they start organizing their knowledge in the form of a script. And so a script is a just like a movie script. It starts with a setting, with a context, and in the setting, an illness script starts with predisposing conditions. So for example, in asthma, we think typically a young person, history of childhood asthma, history of eczema, history of seasonal allergies. That's the context. Like any script, there's typically like a problem. There's a plot. And in asthma, it's allergic inflammation in the airway, right? Reversible bronchoconstriction, allergic inflammation. There's a lot of eosinophils. There's Th2 inflammation. That is the sort of the crux. That's the pathophysiology that centers the illness script, and then that leads to clinical consequences: wheezing, abnormal PFTs, elevated fractional nitric oxide in the breath. And so these illness scripts are how we organize our knowledge in our mind. And so once we have our differential diagnosis, what we do is we go through this illness script instantiation where we start, okay, this patient has these findings and they fit asthma, but they have these findings, they fit COPD, and this allows us to compare and contrast our differential diagnosis. So this is the diagnostic process in a nutshell, and how for us to teach and assess clinical reasoning, we really need to break it down into activities. So here, what I'm showing is that if you think about a one-size-fits-all educational system, where we have, these are the 2 years, this is the program, and these are the rotations you need to go through, and this is how we assess. The problem is that you have learners that just learn in a very different way, and so you have for example, your ideal path here is the learner that over time gets better. But in reality, you have people that are like, if you look at this classroom achiever, they do very well early on in the classroom, but once they go into the clinic, something happened and they lose their proficiency. If you think about the stagnating learner, this is a learner that's going through the one-size-fits-all education system, but is going under the radar and is not being supported enough for them to reach the ideal path. And then if you look at the unsupported learner, such as these are folks that something happens in their lives, something happened in the system, that they are dropped, and so they do well, they're along the ideal path, and then something happens, and then we lose these learners. And the problem is that when we think about the one-size-fits-all, is we don't capture these. If we only look at our learners once every 6 months or once every few years, we're going to miss a lot of these students, and we're not going to be able to assess how they do. And which is why educational programs are really going to a more of a longitudinal process, where what we want to do is follow our learners over time in a longitudinal fashion. So now, if we think about competency-based education and we think about the clinical reasoning, ideally what we want to do is we want to be at the bedside of all of our students, right? We want to be there when they're thinking about a patient, when they're gathering their history, when they're doing their exam. So whatever the problem that the patient is, and we want to be able to be there to observe their activities, so we can then assess them and provide them feedback, and then so that we can improve that process. But the problem is that this requires us being there all the time, which, even if you have learners in a classroom, or you have 10 students on rounds, providing direct observation to all of them is just not realistic. Well, what about if you have 100 students in your program and some of them are just not in your line of sight? It's really, because it's an impossible problem. And this comes to the crux of the problem of competency-based medical education. We know it's important. I've shown you why it's critical, but how do we do it? And relying on direct observation is too much to ask on you folks, on educators. This is so this is just to, this slide should have been before. This is just to show that what we want to do is really over this longitudinal process. So one solution is to leverage AI and for educators to help AI in the assessment and to help AI in the feedback. And this will really help us, so help the educator stretch themselves enough so they can observe their learners. Now, when we think about AI, there are different types of AI, right? So you have now we sort of become almost so familiar with tools like GPT, but GPT is more like these AI 3.0. These are the more recent forms of artificial intelligence, which are really, really important and transformative. But AI is also, so the more typical AI are more algorithmic, where we leverage technology to gather information and provide assessment by simple regression analysis and coding. And so this is a typical software that can you ask it like a search, right? You put something in your search and you have results. It's a form of artificial intelligence, but it's a basic form. And so what we've tried to do is we've tried to leverage that initial form of AI to begin with. And what we think the solution is to help educators analyze and provide direct observation and assessment and feedback for their students in clinical reasoning is to leverage simulation. By simulation, you can do a few things. First of all, you can expose learners to a diverse and scalable a corpus of illnesses. Instead of having, when they go to the hospital, they may only see a fraction of what they're supposed to see. But by simulation, they can really expose them to a lot more illnesses to make sure that they don't miss anything. The simulation should be done so that it can provide an assessment of the cognitive reasoning, of the clinical reasoning task, of the activities, of providing assessment on data acquisition, on problem representation, on the differential diagnosis, on management. And so the simulation should be able to break down the clinical reasoning into distinct and trustable professional activities. And then the simulation should allow you should provide the educator with precise feedback so that the learner can grow and so that the educators can identify areas of strength and areas of weaknesses and to help the learner grow. And by leveraging technology in this way, you can really support learners, whether they're immediately with you going through a case or hundreds of miles away doing a rotation and going through these cases, and you can then therefore help them out. And so when we thought about NEJM Healer, that's exactly what we did. We created these virtual cases of simulation where we broke down the clinical reasoning process into distinct activities of clinical reasoning so that learners can practice the different steps, but importantly, so that educators can then get insight into these steps and provide the feedback that they need. These are screenshots, and I'll take you in the demo in a second. And these are examples of some of the kind of data that we can get, for example. And so this is where, in Healer, what we do is we break down the encounter into 4 stages. There's an initial triage phase where the only thing you know is the differential, is the chief concern and the vital signs. And then you have a history and an exam. And at each stage, the learner is providing a differential. And so what we learn, for example, in blue are these pre-clerkship students, in green are the post-clerkship students. You can see here that the differential diagnostic accuracy, how good a differential is compared to that of expert, is really poor when they don't have a lot of information. Experts are able to generate a pretty good differential early on, but then it goes up in diagnosis. So if we use a typical simulation where the only thing we look at is how good their differential diagnosis is at the end of a case, yeah, I mean, they're going to do very well. Everybody knows that this is a pulmonary embolism if the CT scan shows that there's a PE. But by breaking down the case in this fashion, we can really capture this early hypothesis generation. Okay, I'm gonna go to a demo, and then I'll do my best to track it. So this is meant to be interactive. In fact, I'll be working with my colleague Goran, and the way we're going to do this, so I'm going to take you through a NEJM Healer, and then we'll go through a case, and I'm going to simulate as much as I can the educator and engage with Goran, who's going to be will be trying to solve this case. In the meantime, please feel free to drop in questions in the Q&A, and if somebody from the team can just let me know, and then hopefully this could be fun and interactive for everybody. Okay, so by the way, I don't have a view of who's on, who's not, so feel free to interrupt. So this is the learner view of Healer. So if I'm a student, I go in, that's how it looks like. Educators will have their own view where they can look at every student. They can look at every case that the student did, and they can look at, they can get very granular information for every learner. For this webinar, we'll just focus on just a case. So we have this case here. I'm gonna so as a student, I have there's a practice library. So these are cases that are available for me if I want to practice on my own, but then there are assignments. So these are assignments that educators have given me. Right now I don't have any assignment. I'm not at Boston University, but here you could actually give assignments for the students. So let's do a case here. Okay. So this is web-based, so it could be done from anywhere. There's a access to the internet, and it's best seen on anything from a tablet to laptop. It doesn't work very well on phone, but you can try. So we tell learners here, so welcome to Healer, and we specifically tell learners what they're going to be assessed on so that they can know what to focus on. I highly encourage folks when they are using Healer, especially as educators, learners need to know. It's like any quote unquote game. You need to know the rules of the game in order for you to play well and win. And so it's critical when you are using Healer to teach them about the clinical reasoning process. And I always say that is it's really essential that for the very first time that Healer is used with students, do it in a group setting. Or maybe have during a lecture or a seminar, you go through a case. You first of all you would break down the clinical reasoning process a little bit like what I did, but much more obviously guided for students. And then you tell them, these are the clinical reasoning steps: gathering information, summarizing them into a problem representation, generating a differential. What is a good differential diagnosis? Make sure to include cancer-Smith disease, etc. And so here, this is a reminder for learner on what they're going to be assessed on. So I'm going to start the case. You can start the case with guidance or without guidance. I'm your guide. So you can see here that I've broken down the case, and the cases are broken down into a triage phase, a history phase, a physical exam, and diagnostic phase. And in each, the task for the learner at each phase is to do three things: is find data that is important to generate the differential diagnosis. In other words, what are the data that define the problem representation? And learners are going to be assessed on two things. One is, how thorough are they in getting the data? And so now, for example, this is a case of abdominal pain. There's probably around 100 pieces of information in this case that are relevant to abdominal pain. If you think about abdominal pain and all the, like what are the data that you'd want to know for abdominal pain? But if you're going to be thorough, it means you may want to capture 100 data. It's too much, and so which is why we also assess data acquisition efficiency, which is of the data that you've acquired, how many are important. And what we tell students is it's important to be efficient, meaning if you select data, they must be important data. Now, data acquisition thoroughness, on the other hand, is really up to you as educators. If you have early students and you want to have them practice, or you want to assess, do they know what data is important in abdominal pain? Like, for example, diarrhea, constipation, like all of these are important. You may want to tell them right off the bat, I want you to be thorough. I want you to be efficient, but also thorough. And so this gives you the flexibility with the learning objectives. And if you're doing this in a group, the way I would do it, I would say, okay, we are in triage. This is the patient. Tell me what data is important. And so, you can go through the triage information here. And then you have your chief concern. And you see this patient comes in here with pain in their stomach. I would pause and I would tell the learners what questions you want to ask for this patient. And then you can engage in this back and forth on history gathering for patient with abdominal pain before clicking that button. So Goran, I'm going to ask you, so this is Betty McMilliman. She comes in, she's in the emergency department. These are her data. What do you think is important? And I want you to think out loud. I want you to tell me why it's important, and then tell me to select it or not.
Thank you. Hello, officially to everyone listening. So when we have a patient like Betty and to do triage in the emergency department, we can look at sort of the general information that we get from the patient, we get for the patient, and then we have the questions. From the general information that's on the left side, I think the important aspect is her age, because she belongs to the older people group, so she's 78. Her sex, in this case, recorded at birth, and the self-identified gender is the same, so let's go with sex at birth. Then her blood pressure being low is a very important finding in this aspect. Her heart rate as well, which is elevated, her respiratory rate, which is also elevated. And can we scroll down to see what else there is?
That's it. Her body mass index is
Oh, that doesn't show. Body mass index is also important. It's hidden.
yeah. Yeah, and again, it could be, it could not be. The fact that it's red means it's outside the normal range. It doesn't
Yeah,
mean that it must be selected, but it sounds like you want to select it. And so you can see here that when I select the data, it adds to this diagnosis pad. It's we've imagined here like a notepad. A learner can go in and see the data they've selected. They could sort of remove data if they want, but this is where it's found.
yeah.
So
One more finding that I
yeah,
feel is important is also her temperature, because in this case, even though her temperature is normal, that does guide us through the process, and it helps me sort of thinking along the lines of differential diagnoses as well.
very nice. Before we go into abdominal pain, we know this patient is here. What brings you here today? I've been having pain in my stomach. Goran, can I ask you to right now, what's the problem representation? Could you summarize what you said in one line? Like how would you describe this patient to a colleague?
Yep. So this would be a 78-year-old female who's presenting with acute onset generalized abdominal pain, who also
We don't know
has.
yet. We don't know yet it's acute.
Oh yes, because we didn't ask the questions. You're absolutely right. I read the abdominal pain, right? The pain in her stomach. So she also has tachycardia. She's hypotensic. She has hypotension. She has increased respiratory rate or tachypnea. And that's all we know for now.
I'm going to add and afebrile because it sounds like you're using the lack of fever as important. Can you start like you're a very, very smart clinician. You're probably familiar. Can you give me like just right off the bat 2 or 3 diseases? Abdominal pain, tachycardia, hypotension, no fever.
I would go with rupture of aortic aneurysm. So RAAA.
Yeah. So you can see I typed AAA and then I have options. What
Yeah,
I tell students here is be specific, be as specific as you can. So for example, it sounds like you said ruptured, so I'm gonna choose ruptured abdominal aneurysm.
Yes, because along the lines of just sort of thinking about it, her blood pressure being low and dropping and her heart rate being up, this wouldn't be a stable AAA. So
Yes.
that's why I said ruptured. This could also very well be, let me think, it could be SBO, which is a small bowel obstruction.
Yeah.
Given
Okay. So
could
okay,
be
now go ahead.
diverticulitis as well.
Diverticulitis, interesting. Sounds good. So, okay, now let's click. So what you bring here today, pain abdominal, pain in my stomach. So I click on that. What follows are the series of follow-up questions that you would typically ask a patient with abdominal pain. And here, we've done it this way because this allows, especially early learners, to learn a sort of, what are the key questions to ask in patients with abdominal pain. Now here, the patient says, when did it start? It started this morning. So if you want to sort of go around, maybe read a few and tell me which ones are important.
Yes, so we want to assess sort of the quality, the quantity of pain, but also just the timeline of what happened. I think scale, meaning 14, she's saying it's very painful on a scale from 1 to 10 is very important. I've noticed that sometimes patients like to kind of tell you that it hurts more than it does, but in this case, it does seem like it hurts, especially because she says 14. Then the pain being all over is also an important finding because we always, with abdominal pain, love to specify in which of the 4 quadrants the pain is. The sharpness of the pain is also a finding because, we want to know what's the quality of pain and how does it go. Then move around or affect other parts of your body is an important finding because when we're assessing abdominal pain, we want to know if this radiates toward her back or radiates toward her shoulder or it doesn't radiate anywhere. The pain getting worse is also a finding in of itself because we know that, it passes over time. Yeah, but I feel
Yeah,
like
that's good. And then
most
there's this one. When did it start? It started this morning.
timeline
And
wise,
so
yeah.
and so, Goran, how would you edit your
Yeah, so
problem?
I would hear at acute onset because it started this morning and she doesn't seem to have had issues previously. And we can call it, apart from acute onset, we can call it high pain, severe pain,
Acute, severe, non-radiating,
non-radiating as well.
diffuse abdominal pain.
Even sharp, I would add.
Use sharp abdominal pain. Okay, great. So, and you can, this is a critical step. And I highlight this to students and residents and fellows all the time. I often, when I work in the ICU, I see, like interns presenting a case and then they go straight into differential. That doesn't tell you how they've processed that information. And I always ask, what is the problem representation here? What is the problem that we're trying to solve? Because you could have the differential diagnosis could be terrible and you don't know why. But when you ask them to summarize the case, you realize that they focus on the wrong data, or they summarize the data in the wrong way. They didn't think about the fact that they're febrile, so on and so forth. This step is essential, and I would really reinforce learners to always keep updating the problem representation. And in Healer, is the great thing is that we capture the problem representation and the differential diagnosis at each stage. So when I move to history, this is going to be saved, and I'll be able to see it. Now, for the sake of time, I'm just going to go a bit quicker. Is there one disease that you want to add that we didn't consider here?
I would add two, actually. One would be acute pancreatitis, and the other one would be acute mesenteric ischemia.
Okay. If I had time, I would ask Goran to think out loud, explain his reasoning. This is another critical step, is to ask your learners to elaborate. The one thing that is really, obviously I'm biased, but one thing that I really think is really cool in Healer is, here we ask them to write a problem presentation, but you could also tell them, write a problem presentation and justify your differential diagnosis. And so because this textbook here is saved and you capture it, and you can actually, for example, I say, I think this is acute mesenteric ischemia because I've seen something like it before. I have no clue what else is going on. And this is saved, and this is where you can capture it. And so you could use this like if you want, like almost like an OSCE. You want, and then they can change. You can, if you ask them to have a clinical reasoning argument at each stage, you can really get a nice window into how they're thinking. Okay, so now I move on to the rest of history. For the sake of time, I'm just gonna sort of just orient you a little bit. So the other thing I failed to mention is Goran, what is your number one differential at this point?
Ruptured AAA can stay, but I would move acute mesenteric ischemia upper, maybe number 3, and keep SBO as number 2 for now. Yep.
Very good. So you can see here I can rank my differential.
Yeah.
Now, and this is where this is different from a case report or typical case-based learning. This case, there's a full medical history, there's a full family history, full social history, and a full review system. And this is where, and this is a critical step, because we are basically engaging our learners with hypothesis-driven data acquisition. What I tell learners here is use your differential diagnosis. And this is why it's so critical to have a rich differential diagnosis early on. Use your differential diagnosis to guide what you ask for, because if you don't, you're going to drown in how much data there is. This is also where, if you're talking to an early learner, they may not know how to approach abdominal pain. And this is where we would encourage them to use diagnostic schemas or frameworks on how to approach abdominal pain. For example, abdominal pain, you need to ask, is it acute or chronic? Is it fever or no fever, like Goran did? And then, based on these, you have your differential. Okay. And this is where they start using their illness scripts. I have an illness script of acute mesenteric ischemia, for example, where it's pain out of proportion to the exam. So I know that for me, the exam is going to be very useful for that. Patients are typically older, they have cardiovascular risk factors. Small bowel obstruction, I know that they need also risk factors like previous surgeries. A AAA, I think about risk factors. So the differential should guide my reasoning. And again, this is why it's really critical to pair Healer cases with teaching them on clinical reasoning and how to get data. So for the purpose of time here, and the other way, sometimes I play with the learners, I say, every student can ask me one question, right? Because otherwise we're going to spend hours here. So Goran, you have one question. It could be a question in a review system. It could be a family history, anything like that. So if you think about your differential diagnosis, Goran, what do you want to know?
Well, just simply because with one question, I can kind of think along one of the diagnoses. I would ask if this person passes stool or gas.
I like it. So if we go, so here, you go to GI, and so these are all the GI questions. So we can see here, the patient is nauseous, no bloating, no burping, any vomiting, no. So this is the abdominal pain here.
Yep.
And then vomited blood, no. Any diarrhea, no. Constipation, no. And so the patient is not constipated, and so you could add it here, no constipation. And so presumably this may lower your SBO.
Yes. Yeah, it goes
And-
lower.
Great. Okay, so I'm gonna again continue for the sake of time here. Do you want to make a change of differential? No, I'm going to continue. It's important to tell your learners to edit as they go so that these things are saved. If they don't, then you miss an opportunity to look at how they're thinking. And this is the physical exam. So again, you have one exam. What do you want to do?
Gastrointestinal in this case, or abdomen.
So I go to abdomen.
Yep. Yeah, we need to know if it's distended.
So you have one. Do you want to look at it? Do you want to listen to it? Do you want to?
Well, we could listen to check for SBO, but palpation, I think, will give us more at this point.
Yeah. So by palpating the abdomen, there's no pulsations palpated. Is this relevant?
Finding, yes.
Yeah. Mildly distended.
Yes.
Fluid wave absent.
Sure. The guarding is important.
No guarding.
No guarding.
No organomegaly.
No tenderness.
No tenderness.
And
Okay.
really, this did switch my order of differentials because now ruptured AAA will go down because no pulsations. So it's still on the list because I think some 40% of them can be there without palpations. But in this case, it does move it below.
Very good. Very good. And yeah, I think this looks good. I would say here, no constipation and no abdominal tenderness. And then here, I'm going to say, aha, the pain is out of proportion to the exam. This makes me think of acute mesenteric ischemia. Great. And we continue. Okay, now, so this is the diagnostic stage. In the diagnostic stage, these are tests and results and findings and x-rays that are already been done. This is not, I'm not ordering these tests. And this is where we play with the difficulty level of cases. In easy cases where we really want them to know, to learn the illness script of let's say, a small bowel obstruction, we have a lot of tests, including an ultrasound, a CT, the whole shebang. More complex cases, they come here, you may only have a CBC. And then so it's really up to them to think about what kind of test they want to order. And so here, just to, we can go to there's already a CT scan. And if I click on the CT scan here, there's a CT abdomen with contrast. We show all the results again, because it's really up to the learner to think what's important. This almost reads like a report of a CT scan. And so, for example, if appendicitis was on my differential and appendix is unremarkable, in fact, I'm going to select it. I had bowel obstruction here. Bowels, no bowel obstruction, I'm going to select it because it's relevant. In fact, it sort of brings it further down. I could even delete it if I want to.
Yeah, and abdominal aorta is an important finding because there's no findings noted.
Yeah.
And ruptured one is on the list. Then we have pancreas, that no abnormalities are found because acute pancreatitis is on the list as well. And then I see CT angio in the lower part that says sharp cutoff noted in superior mesenteric artery, which is an important finding.
CT abdomen with vessel occlusion. Now you can see here, I wrote this. I mean, I used a lot of medical terms, and this is where you also have a window into how your learner is thinking. on the terms that they use. You want your learners to use semantic qualifiers, medical terms, and that sort of gives you a window into how they organize their knowledge. And this is also where you could tell your learners, before going further, I want you to write your assessment and plan. And then you can say here, and this is where you can ask them to write their reasoning even more, and becomes like an OSCE. So you can use this almost like an OSCE augmenter. Again, these are not real patients, but it allows you to obtain at scale clinical reasoning arguments. Just checking on time, we have 5 minutes here. I'm going to continue. Now here we are starting to get into we tell learners to finalize and reflect. You want to make changes to your differential before we lock it in? I think we don't. Goran thinks that this is acute mesenteric ischemia. Rate your confidence level. How confident are you, Goran, that this is acute mesenteric ischemia? You know it is? You think so? Or well, we know it is because it's this.
Yeah, we know it. We have a CT angio.
Yeah. It'd be a problem if you'd say, well, if you say that I'm unsure, have no idea, or you're wrong, it means that they did not see the finding in the report, which is actually a real problem. Often data go into in the HR and we miss them. How mentally demanding was this encounter? This gives us an idea on the cognitive load of the student. You want the student to be somewhere in the middle. If it's too high, it means they're not learning. They're overwhelmed. If it's too low, they're not engaged. It's either too easy or they think it's too easy and they're not engaged. So I'm just going to give it here. And so the first thing we do is we give some interval feedback. We tell them we talk about their data acquisition efficiency and thoroughness. Goran was very efficient. He knew what was important and did not spend a lot of time looking at stuff that is maybe important but did not have the differential. So they were very efficient, and he was thorough, and his thoroughness was actually low. And in fact, this is where experts are. Experts are efficient, they're not thorough. And this is where you can play with your in fact, if you have a resident that they're not doing very well, or a learner that's not doing very well, and you find that they're being always very thorough, it means that they're not knowing how to focus their approach. And so you can use that information this way. Top 3 diseases I'm going to skip for now, but this is just to tell learners what were the top 3 diseases that the expert who played the case considered in this case. It says here missed, and that's because we removed them from the differential at the very end. They're not scored on this, but this is sort of just orients the learner onto what the expert was thinking. So I think we did a pretty good job here. Next is we asked them to confirm the illness scripts. And so here what we do is, okay, these are the 3 diseases that the expert considered, ruptured AAA, acute mesenteric ischemia, and an SBO. And then these are findings that an expert used to compare and contrast. So there are findings here. There are findings here that increase the likelihood of diagnosis, and then there are findings that decrease the likelihood of diagnosis. And what we tell students here is they need to drag and drop these findings into the Venn diagram. So, for example, the fact that this patient is old, is a risk factor for, I'm going to say all of them, but maybe not necessarily SBO. I'm going to put it here. Now, the patient had AFib, and AFib can throw clots. And so it's a risk factor for acute mesenteric ischemia, and they were not on anticoagulants, and definitely makes mesenteric ischemia more likely. They have hypertension, is a risk factor for AAA. They had the history of a C-section, is a risk factor for small bowel obstruction. The pain started hours ago. That's common to all 3. They have abdominal pain, it's all 3. They have no tenderness. The absence of abdominal tenderness really supports AAA. The lactate was high. I'm going to put it in the middle. The fecal occult blood test was positive. I'm going to put it here. And the CT angiogram is here. And you can see the CT angiogram, which is data 11, is a dark green, which is a rule in. And so now how about the red ones? So these are like the absence. So abdominal pulsations, none, makes AAA less likely. The CT of the abdomen showed a normal aorta, so it rules out AAA, and there was no small bowel obstruction. It rules out SBO. And so you look at this Venn diagram, it tells you that, okay, I know why this is acute mesenteric ischemia, because all of the data fits mesenteric ischemia, and there were data that ruled out SBO and a AAA. And I submit this, and then this is where I say, okay, which is the most likely? I think we're going to say mesenteric ischemia. And here, depending on the level of your learner, this is where you tell them to type their if they want additional tests. I'm going to, for the sake of time, just referrals, treatments, counseling on the patient, and then what do I do the patient? Do they want to admit them or send them back home? And then how concerned am I about the patient? I'm very concerned they could die. And now I submit my case for review. The first thing we tell learners is to self-assess their problem presentation. And so this is what the expert wrote, and the problem presentation, this is what I wrote. You can see here that I'm capturing everything, and so really a lot of opportunity to do here stuff. And then they self-assess. Like, I think this is similar to the expert. And same thing for management. This is, I mean, again, and here, this is where learners can really get a sense of how expert thought about the management for this patient. And then finally, we give them the complete feedback on how they did. So this is, Goran, this is how you did. Your efficiency was very high on the data acquisition. Thoroughness was low as expected. Your diagnostic accuracy was spectacular. Your lead diagnosis, so you knew this was a case of acute mesenteric ischemia. You were right. But also, more importantly, your differential diagnostic accuracy was good, meaning how you built your differential through the case was high. Often we'll see learners that are score very high in their lead, but they're very low in their differential. And that's because they can recognize a CT angiogram that shows a mesenteric ischemia, but they were struggling in their differential diagnosis. And then a learner can really dig deep into the feedback. And here in Healer, what we've done is at each stage, for example, the triage stage, this is the expert's differential diagnosis, and this is my differential diagnosis, and this is the rationale. This is how the expert thought about the case. So a lot of learning content here. So that's the case. For the sake, I'm going to stop and see if there's any questions. But there's a wealth of information. All this is saved in the educator portal, where educators can go in and look at reports, look at how students did over time, and dig in into each case. You as educator could actually come here and you can look at the problem representation of your learner and get a great window into how they're reasoning with the case. Thank you.
That is excellent. Thank you, Dr. Abdulnour, and thank you, Dr. Stepanovsky, for participating as our model student today. So we do have a few questions, and then I'm going to give you all a little bit of follow-up information at the end. If for some reason you have to leave early, please check your email. There'll be a follow-up email as well. So I'm going to start with a couple of perhaps more direct or easier to answer questions, and then we'll go to the ones that are a little more philosophical. So the first question is, are there actual images available under investigations, or is it just summaries of reports inside a Healer?
So right now it's only a summary of reports because we want to focus on data, on information processing and data processing, but it's on the roadmap to add images. Excellent.
Another question, and that first question was from Manther Abumafuz. The next question is from Kaberi Dasgupta, asking, it looks like all the questions and answers are given up front. Wouldn't it be better, or is it possible for the learner to propose some of those questions?
It's a great question. So we've tested different methods. Asking learners to propose a question, and when we thought about this was before large language models. It required, having a technology that would recognize a question, which now exists, right? And so this is certainly where like this is number one on the list after images. But what we are considering doing is a mode where you have all the questions laid out, but no answers, and it's really up to the learner to look at what question they want to ask and select that question so that they can see the answer. This will give us a window into, do they know the right question to ask, right? As opposed to selecting the result. That's a great question. That's also high priority.
Excellent. And we also had a question from Dennis Baker about the value of having the student think out loud. And I think you modeled that fairly well today, but I wondered if you could speak a little bit more to that.
Yeah, there's been a lot of attempts and studies at thinking how we assess clinical reasoning. And what I've seen through the literature is that to date, the most effective way is to capture the clinical reasoning argument of the student. And the only way to do so is by asking them to think out loud or by asking them to write down the case. The problem about writing down, like if you think about an assessment plan after an OSCE, is that you're capturing the reasoning afterwards. Meaning, let's say I go through this case right now and I see that there's a CT angio showing an acute mesenteric ischemia. I'm going to say, this is a case of acute mesenteric ischemia. I'm going to write my assessment and plan knowing it's a case of acute mesenteric ischemia. And so as an educator, you'll miss a lot of the initial steps, which is why in Healer we've broken down the process so we capture that early hypothesis generation. So that's why it's important to capture it. The challenge is in how do you assess a clinical reasoning argument. There's different tools out there to do so, that the validated questionnaires. I can tell you this is probably going to be the very first thing that large language models are going to be helping educators with, is assessing free text.
And to that point, we had a comment that I'm going to turn into a question because I think it's really applicable to that point. Is clinical reasoning a skill that is a dying art form due to the availability of technology? Is it more useful in a low resource setting, or do you believe this is still something that's vitally important to be teaching clinicians?
I think in the era of, there's so much technology out there. There's so many tools, and that it's actually more important to teach the reasoning process so that the clinician can know what to ask. We see it all the time. A patient comes in. When I see patients come in the ICU, they've gotten all the tests in the world and all the treatment in the world, and so the cost and the risk on the patient are tremendous. By teaching the clinical reasoning process and telling students to use their differential diagnosis to drive testing and treatment, like we did today, and that's been shown, will significantly decrease utilization and error. I think it's critical in both high utilization and low utilization. It's an essential. I mean, it's probably the number 1, 2, 3, 4 reasons we must teach the clinical reasoning process is to improve outcomes.
Thank you. And I have 2 more questions, and then we're going to move to where we can give you all some information about Healer and how you might investigate that a little more. So one question is from Raja-Elie. How would this competency model, the competency model you spoke about at the very beginning of the presentation, how do you apply that to ethical issues?
So, I break down everything in my mind, everything is information processing, including, and this is sort of my interpretation of my own learning, right? So this is probably not what you hear a lot of people say, but any decision we make in life, in the hospital, including ethical decisions, involve information processing. In other words, to make a decision and decide whether it's ethical or not requires us to really get a sense of the context of the patient's wishes and desires, of the context in which we're thinking about, and determine, what are the potential decisions I need to make, and then trying to find the solution, the decision that best matches the patient. It's a form of clinical reasoning. The cases in Healer obviously are much more about diagnostic reasoning, and as opposed to ethical reasoning, but there is no reason why a similar approach could not be used to highlight cases around ethical reasoning. And so this is sort of, we can talk about it later. I'd love to consider it later, but you can totally see how we can create cases where the data presented, where the learner should first of all identify what is the ethical problem I need to solve here, and then what are the potential solutions. And you can see that all of these steps are the same. That's my take.
Excellent, thank you. And one more question that I think is a great one. When you have patients to see, how do you find time to do all this in routine clinical practice?
Okay, so I'm presuming this question is, can you use this for continuous medical education as a practicing clinician? I think this is really designed. I mean, it's like almost like seeing a patient. So you'd need to have blocked some time off for this, and it's not really designed for it. We have been thinking about taking a version of this for the practicing clinician that you can do like in 5 minutes. But right now, this is really geared for a curriculum, right? A school, a residency program, a medical school. and it's a deliberate effort where you have to give time for your students to do so. It takes on average, if you're just doing a case, it can take 15, 20 minutes, depending on the level of the learner. If a learner wants to dig into the feedback and learn more, it can take more. That's how it is. But it takes a lot of time to do.
Excellent. Thank you.
Great. And then are there specialty-based content that's sorted? Yes, you can sort your content through the cases through by content expertise. How many experts contribute to the expert content for each case? There's at least 3 experts that play the cases blind, so they don't know what the case is about. And then there's at least 4 editors that are going over the case and providing insight. They're not blind. And so overall, there's like 5 or 6 expert clinicians going through each case.
Excellent. Thank you. And Lecturio has acquired AnyJame Healer. So if you are more interested in finding out about AnyJame Healer, you can scan the QR code that's on your screen, or watch for your follow-up email. There will be a link there and more information about that, how you can check it out and get a demo or access to try out a case. There's a question that just popped up. Is there an AI component to Healer? Would you like to address that?
So I'm gonna presume, is there an AI is there more like a large language model component to Healer, or a more recent component to Healer? There is already, like I mentioned, this sort of like 1.0 AI, meaning like how the data is captured, is processed. It's a form of AI, but now when we think AI, we think GPT-4, which is a completely different generation. Not implemented. Lecturio has an AI, I think an AI tutor, and again, it's pretty obvious that we're thinking about how do we leverage that technology and to bring it into Healer, not only for interacting with the patient, but what I think is the money is as a coach, where you can have an AI actually, like an AI coach that's there. So think about this model of having a direct observation, right, for learning. Well, imagine having that there. Early testing suggests that there's a tremendous potential. So that's a great question. And there was a question around access in low and middle income countries. Obviously, it's very important for me because I come from such an area. I grew up there. And this is why we designed it to be web-based. That's all you need is access to the internet and a screen that's, I think, 11-inch in diameter or bigger. I'm not talking about cost. Like, that's not my... I would love it to be available to everybody for free, but that's why I'm not the CEO of a company.
Excellent. And thank you to Dr. Velasco and those of you who have some experience using Healer and are talking about it in the chat. We appreciate you. So absolutely. And I'll share some follow-up information. We've got a couple more events coming up around this topic. So Dr. Abdulnour, I want to thank you again for that incredible presentation. I know I learned a lot. I think we all did and are really interested in learning more. So we're going to share a recording with you along with a follow-up survey. So please watch your email for that. And if you would like an attendance certificate for this seminar, there's a place for you to mark that on the survey form that's going to appear in your email. So if you'll mark it on the survey, you'll receive a certificate of attendance. Now, if you're interested in more of our events, we have an event on space retrieval, retrieve to retain, space retrieval in medical education. And that's about space retrieval, space repetition. That's with Dr. Adonis Wazir, coming up on Wednesday, June 26th. You can scan the QR code on your screen, or again, the link will appear in the chat and also in your email. And then on the clinical reasoning topic, we have clinical reasoning and formulating a differential diagnosis. And that's Dr. Stephen Holt. That's going to be another great webinar. A month from now, that's Thursday, July 25th. So please scan the QR code to register, or again, you'll see that in your email. And if you have more questions, you can reach out to learning-science@lecturio.com. You can always go to the Lecturio website and send us an email. We would love to hear from you. But I think that's everything that we have the time for today. I very much appreciate your questions and all of the great participation. Thank you again to our speaker, Dr. Abdulnour, and to Dr. Stefanovsky for helping us out today. And I want to thank you so much, and I hope to see you at our next webinar. Thank you.